Good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to yet another edition of very educational lectures for you. The speaker for the first session of today is our honored guest from the USA, Professor Tan Nguyen. Professor Tan Nguyen is the Director of Interventional Neurology, Neuroradiology at the Boston Medical Center and Professor of Neurology, Neurosurgery, and Radiology at the Boston University School of Medicine. She is the president-elect of the Society of Vascular and Intervention Neurology, the first woman in its 15 years. Congratulations. Her clinical interests are focused mainly upon intervention neuroradiology. She has been involved in a total of 3,000 INR procedures, including more than 500 interventions for aneurysms in the form of coilings and flow diversion and 400 acute stroke interventions. Her other clinical interests include neurocritical care, preoperative embolization for head and neck tumors, carotid and intracranial stenting, subdural hematoma embolization, vertebroplasty, and kyphoplasty for acute spinal fractures. Dr. Nguyen has authored more than 150 peer-reviewed publications, contributed to national guideline statements and book chapters. She is the reviewer for neuroendovascular section of 8 neuroscience journals and had more than 80 presentations at scientific meetings on a national and international level. She serves on section editor of Stroke, editorial board of Journal of Stroke and Cerebrovascular Diseases, Journal of Neuroradiology, and associate editor of Frontiers of Intervention Neurology Journal. We are extremely thankful to her for accepting our invitation to be a speaker at our webinars, and today she'll be talking about image selection for endovascular thrombectomy in the late window. The speaker for the second session of today is our honored guest from Pakistan, Professor Syed Athar Enam. Professor Enam is a professor of neurosurgery and chairperson of Department of Surgery at the Aga Khan University Hospital, Karachi, Pakistan. He joined the AKU as an associate professor in neurosurgery in 2003 and developed a state-of-the-art neurosurgery program that has trained a new generation of surgeons for Pakistan. Dr. Enam has published acclaimed research on brain tumors and is an expert in minimally invasive spine surgery. He has been a recipient of several awards and honors, including the Excellence Award in Neurosurgery by the Pakistan Society of Neurosurgery, as well as the prestigious Sitara Imtiaz Award, the third highest civilian award by the government of Pakistan. He is a life member of the Sigma C, a scientific research honor society, as well as the founding president of the Pakistan Society of Basic and Applied Neurosciences. We are extremely thankful to him for accepting our invitation to be speaker at our webinars, and today he'll be talking about benefits of awake craniotomy in resource-limited settings. The chair for this first session of today is our distinguished faculty from Japan, Professor Shigeru Miyachi. Professor Miyachi is the professor and director of Department of Neurosurgery and Neuroendovascular Therapy Center, Aichi Medical University, Aichi, Japan. He is the president of the Asia Australasian Federation of Intervention Therapeutic Neuroradiology. He was the past president of the AFTIN Congress in 2012 and vice president in 2014-15. He is a noted author with several publications in various peer-reviewed journals. He has received several awards, including the Best Doctor of Japan award in the past. We are extremely thankful to him for accepting our invitation to chair the session of Professor Tan. The chair for the second session of today is our honored guest and senior faculty from India, Professor Dilip Panikkar. Professor Panikkar is one of the most famous faces of neurosurgery in India, who currently serves as a professor and head of Department of Neurosurgery at the Aster Med City Hospital, Kochi, India. He had a long, outstanding career earlier, having served in prestigious institutions like Sri Chitra Hospital, Trivandrum, as well as Amrita Institute of Medical Sciences, Kochi. He is an important member of the Neurosurgical Society of India, as well as Skull-Based Surgery Society and Stereotactic and Functional Neurosurgery Society of India. An exceptionally talented neurosurgeon with more than 31 years of experience to his credit. His areas of special interest include neuro-oncology, endoscopic skull-based surgery, reconstructive surgery for craniofacial deformities, functional neurosurgery, and neurovascular surgery. He is an invited faculty to various workshops and conferences around the world. He is also a noted author with several publications in various peer-reviewed journals. We are extremely thankful to him for accepting our invitation for chairing the session of Professor Syed Athar Enam. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely thankful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Boon Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Shigeru Miyachi.
So as Raja introduced, Professor Tan is a very famous professor about the mechanical thrombectomy and the imaging. And her today's title is Image Selection for Endovascular Thrombectomy in the Late Window. Yeah, this is a very hot topic because mechanical thrombectomy is very important maneuver and very important so method for the emergency stroke. And also, this is not only the neuroradiological field, but neurosurgeons. And it is so very important and very important for all the neurosurgeons, because particularly in Asian countries, the neurosurgeon has a big contribution for the emergency stroke. And the mechanical thrombectomy is, for example, in Japan, the mechanical thrombectomy is one of the important maneuver to learn for all the neurosurgeons. So this topic is very hot, and because now the mechanical thrombectomy is a very good result, and maybe the more than 90% will be successfully recanalized. So, but so remaining issue, for example, very low aspects patients or very high aspect ratio, aspects patients, or the medium vessel occlusion, and also as a result of a dawn or diffuse 3, such a late time window, that we have a very difficult to select or to triage the patients. I think the Professor Tan will have this very good key or very good point to learn and to have a good selection for the patients in the right time window. And as you know, she has a very excellent issue papers in German neurology for the same contents. So I think I look forward to listening to your direct lecture. Okay, Professor Tan, are you ready?
Yes. Professor Miyashi and Professor Krishnan Kuti, thank you so much for the invitation and the very kind introduction. It's a great honor to be among colleagues from Asia CNS, and I'm happy to share my slides. So the topic today is looking at imaging selection for patients in the late window. These are my disclosures. Most pertinent is I have received research support from Medtronic and SVIN for this project. As introduction, as you know, DAWN and Diffuse 3 trials really revolutionized how we treat stroke patients in the late window, being 6 to 24 hours from symptom onset. And the important things to notice from these trials was that advanced imaging with CT perfusion or MRI were the mainstay of selection for patients to get into these trials. However, the issue is that advanced imaging is not widely available. Dr. Greg Albers, who was the principal investigator for the Diffuse 3 trial, wrote a very nice editorial in Stroke soon after its publication, indicating larger benefits of treatment with later treatment. And he called this the late window paradox, whereby if you compare it to the early window, patients who were treated in the later window seem to have a wider treatment effect, as you can see from these wider margins between endovascular therapy versus the control arm in the late window compared to these narrower windows in the early window with the Hermes analysis. And the explanation for this was that because they used advanced imaging, they were so good at selecting patients that this is probably why we had this wider treatment effect. Whereas in the early window, you were permitted to use CAT scan as your triage of choice. And so Dr. Albers had a nice commentary saying, because access to acute MRI is limited, unless you're in Japan, of course, CT perfusion would be required to select late window stroke patients for thrombectomy at most hospitals. And these trial methodologies and the guidelines trickled into the AHA guideline, whereby they're saying that it is recommended to use CT perfusion or diffusion-weighted MRI to triage patients for LVO in the 6 to 24-hour window. It's a level 1 indication, and that's natural because that was the method by which patients were selected into these trials. So naturally, the guidelines follow the methodology of the trial. And so in the ESO, the European Stroke Organization, along with ESMINT, they also mentioned that it is necessary to do advanced imaging in the late window with a strong recommendation. And in Canada, again, beyond 6 hours, one would require additional advanced imaging to triage patients to be treated in the late window. The issue with the advanced imaging recommendation is that it is not widely available. My colleague, Dr. Sunil Sheth, and colleagues in Texas did the study of patients with acute stroke presenting to hospitals in Texas in a Medicare data set. And basically they found that most patients presenting to these hospitals with stroke were presenting to hospitals that did not have CT perfusion. 69% were going to hospitals that did not have CT perfusion. And if you think of Texas as a microcosm, meaning a paradigm for the United States, and being a well-resourced microcosm, you can think about the disparity in availability of advanced imaging in other states. And this study was as of recently 2017. And then we take this to Africa, where recently this nice paper by Dr. Rushdie and Dr. Shokri looked at the availability of treatment modalities and imaging in Africa, and you can see this disparity widens. So if we think about the goal of imaging, it is really to identify patients who can benefit from treatment. A less appropriate goal of imaging is to triage patients that may have better outcomes than others. And this is in the context of an individual patient. Jean Raymond is my mentor from Montreal. He had this nice quote saying that better clinical outcomes can be observed among patients selected on optimal CT perfusion or MRI parameters. But this selection can improve your overall statistics at the potential cost of denying care to many patients who could benefit. So the objective of our study, which was the CT for late endovascular reperfusion study, was to evaluate the clinical outcomes of patients with proximal anterior circulation large vessel occlusion in the 6 to 24-hour window selected by non-contrast CT and CTA, of course, to look at the vessel occlusion versus CT perfusion or MRI. And the primary endpoint was 90-day MRS distribution, and the secondary outcomes are as listed. Our pre-specified hypothesis was that there would probably be no significant difference in outcome if you selected patients based on non-contrast CT compared to if you selected based on advanced imaging. This was a multinational cohort study of consecutive patients between 2014 to 2020. ICAT, M1 and M2 occlusions were included in the study. So very similar to the Dawn and Diffuse 3 guidelines, other than we included patients with M2 occlusions and also patients with baseline MRS of 2, which was not included in Dawn or Diffuse 3. This is a flow chart to show how we arrived to our final cohort of about 1,500 patients in a complete case analysis for the study. And so overall, we had about 500 patients selected by non-con CT, 750 by CTP, and 300 by MRI. And for vessel imaging, CTA was by far used in the majority of patients in 98%. For those who used MRI, we saw MRA as the modality for LVO selection in about 270 patients. And these were patients mainly in France and Germany. For baseline characteristics, I draw to your attention the baseline NI stroke scale coming into the study was quite high, 17, just like in the early window. And if you look at the status of patients in terms of transfers, we saw more patients selected by CT if they were transferred, and also by MRI as well. And more patients in the IV-TPA treatment group underwent MRI compared to the other modalities, which is natural thinking about the Wake Up and Extend trials where they selected patients based on MRI. In terms of baseline aspects, it's important to note that most patients in the study had very good looking aspects, whether they were selected by CT, CTP, or MRI. The median aspect score, or the Alberta Stroke Program early CT score, an indicator of how much infarct you have on your baseline CAT scan, was 8, and the interquartile range was about 7 to 9. So 75% of our patients had baseline aspects between 7 to 9. And what we found was that essentially there was no difference whether you were selected by CT versus CTP versus MRI by 90-day ordinal MRS shift. The secondary outcomes were to look at functional independence. And again, it was largely similar. And we had higher reperfusion for TICI scores in the patients who were selected by non-contrast CT and CTP compared to MRI. Safety outcomes are important to report because obviously we worry more about hemorrhage in the later windows. And so numerically, it was higher in terms of the symptomatic hemorrhage in the non-contrast CT group compared to the advanced imaging group, but it was not statistically significant. and mortality also numerically higher among the CT selected group, but again, not statistically significant. We also looked at time metrics, meaning how much time did it take for patients to get imaged to puncture, whether you were selected by non-con CT versus advanced imaging. And the interesting observation, as you would surmise, is that patients who were selected by non-contrast CT had shorter door to puncture times compared to those who were selected by advanced imaging, by about 20 minutes. So if we look back at the AHA guidelines, even in the late window, 6 to 24 hours, they still recommend that evaluation and treatment should proceed as rapidly as possible. So even if you have that later window and you think, oh, I have more time because maybe the patient has more collaterals, you still want to treat your patient as rapidly as possible. So non-contrast CT could be one way of achieving this metric. And then we also looked at outcomes for those who arrived directly to the mothership patients, meaning directly to the endovascular centers, endovascular performing centers. And we found there was no difference in outcomes for mothership patients, whether selected by CT versus advanced imaging. And in our cohort of those who were reperfused, they did better than those who did not reperfuse. And it didn't matter whether you were selected by CT, CTP, or MRI. You did better if you reperfused compared to if you didn't reperfuse. This is a study from my colleagues at Mass General, and they mentioned that in this cohort from the Get With the Guidelines database, that EVT was performed frequently after 6 hours, but the outcomes at discharge were worse compared to those who were treated within 6 hours. And they recommended that further efforts are needed for optimal EVT outcomes in clinical practice settings. My commentary on this study is that while maybe your outcomes are worse compared to the first 6 hours for those who were treated later, really the comparison you want to see is those who were not treated. So what is the treatment effect for those who were treated versus those who were not treated in the late window, and not really compare it to the early window. So the limitations of our study were the retrospective design could have led to selection bias, limiting the generalization of our results. We had differences in imaging interpretation, selection paradigms, and the automatic CTP software across multiple centers could also introduce bias. CTA collateral score was not measured in our study, and most sites did report that collaterals were not routinely used, and obviously that could affect the patient selection. And also, we don't know about the patients who were excluded by the triage process. To further confirm or validate our study, we look at the Aurora analysis. It's a systematic review of patients treated beyond 6 hours. And this is the equivalent of the Hermes analysis for the early window, 0 to 6 hours. And basically, those who were selected with by aspect score still did very well and had a higher chances of good outcome compared to their control group. And so why is this? Dr. Noguera had a nice quote at the recent SBIN meeting. We were discussing this, and he mentioned that CT scan is like, in the late windows, like a red wine. It gets better with time. You can see the infarct better as time goes by. And if you don't believe me, then if you think about, or if you're skeptical, I'd love to draw your attention to the most successful recent Japan rescue study. Congratulations to Dr. Yoshimura, Dr. Sakai, Dr. Yamagami, if you're in the audience, on this amazing study where they looked at patients with large core infarct, showing that even if you miscalculated well your aspect score based on your non-contrast CT, patients, if they had a large core presenting to you, still had a better outcome with endovascular therapy compared to medical group. And the treatment effect was 31% for endovascular, good outcome, compared to medical management, 12.7%. So odds ratio of 2.4 times doing better with endovascular therapy compared to medical. And recall that our patients, most aspects were really good. They were about 8. And so if there is a treatment effect in the late window, and this study also carried out to the 24-hour window, granted, most being selected by MRI, you probably have some latitude to consider your patient for treatment, even if you erred on a wrong aspect score. And congratulations to our Japanese colleagues who were the trial leaders and recruiters for this study. So in conclusion, in patients with stroke due to ICA terminus M1, M2 occlusion, presenting 6 to 24 hours from onset, favorable outcomes selected by CT are equivalent compared to selection by advanced imaging with CTP or MRI. There's no increased risk of hemorrhage or mortality by imaging modality. Door to puncture times are shorter in patients selected by non-contrast CT compared to CTP or MRI. So these findings have the potential to widen the indication for treating patients in the extended window using a simpler, less costly non-contrast CT as an alternative to CTP or MRI. Where do we go from here? There are ongoing studies, MR Clean Late and Resilient Late, that are taking patients in the late window with CT selection only compared to medical management. And if these trials are positive, it would give us level 1 evidence to state that patients can be selected by only a non-con CT compared to advanced imaging. And Walid Brzezinski, interventional neuroradiologist at Mayo Clinic, wrote potentially in this tweet that CT perfusion could go in memoriam. Dr. Tekli, who's an Ethiopian interventional neurologist, when this paper came out, said, great news to developing countries. Having this study to validate the use of non-con CT in the late window could help in areas where advanced imaging is not available. And Dr. Kasravani from Toronto said that having this option could help the field reconsider and pull back from the reliance on advanced imaging for making endovascular therapy more accessible and care more equitable for patients who are impacted by large vessel occlusion stroke. I had the pleasure to meet a colleague from Honduras when I was at the SVIN meeting, and he said this study can give new hope for patients in the late onset for developing countries like Honduras, where essentially I learned that there are practices where after hours, if advanced imaging is not available, you are not eligible for treatment, so you cannot even get treated. And I didn't realize this until I had the chance to interact with several colleagues from around the world. So this was our publication. It takes a village to produce this project. So I thank all our collaborators for their contributions and thank the Asian CNS very much for this great opportunity to speak with you and share some of our thoughts on late window imaging for thrombectomy.
So very excellent lecture. Thank you, Professor Tan.
Oh, thank you, Professor.
Yeah, so very excellent. And but I have some questions. And I agree. You were so CT, plain CT, non-contrast CT is a very effective tool for the selection of the patients for mechanical thrombectomy. But what is a so very so big so advantage that for saving the time or for saving costs or both?
All of the above. All of the above. I mean, we showed that it's maybe 20 minutes faster to bypass the advanced imaging. The interpretation of CTP can take time before you make the decision. So if you can do less with more, more with less, then why not just go with the simpler imaging study? I know in Japan, MRI is widely prevalent and you have very easy access, but it still takes time. And you still have to screen the patient for, you know, pacemaker and metal. So you can skip all that part. Why not?
Yeah. So yeah, this is a very hot discussion all time. And but many hospital for the primary stroke center hasn't always have an MRI. So we have no idea to skip the MRI. So I think yeah, and also but in the late time window, the plain CT will indicate the ischemic area already. So if there's, for example, 10 hours or so 12 hours after the onset, if the plain CT have a so larger area of the ischemic area, we don't do mechanical thrombectomy. But if such a so very late so time, the CT scan looks normal, we go to the mechanical thrombectomy. This is very positively. Yes, I think so. In this meeting, CT non-contrast CT is so very useful, and I think this is only the CT non-contrast CT we can do. We can so decide the mechanical thrombectomy.
Exactly, because if you see the infarct, of course, you're not going to offer if it's completed infarct. And if you don't see the infarct and you say, oh, there's a brain looks good, and you're 12 hours out, then it would be a great patient to take to the lab. And often some of these patients, they go to CAT scan and sometimes they go back to the ER. So you don't lose time going back to the CAT scan to get the CT perfusion or to go to the next MRI, because that will easily cost you an extra half hour if you didn't get it at the same time.
Yeah. And also in the Japanese survey, all 80%, 70 or 80% of the patients treated with the mechanical thrombectomy is not strictly based on the criteria of the reported criteria. For example, the LMIC study or the RCT design or AHA recommendation. 80% is out of the criteria. So in this meaning, the MRA has no useful tool. All the patients will so very positively go to the angiography room. So I think a plain CT is possible to select it.
And there's places that are going even more radical. So the Barcelona group, Mark Rebo and Raul Noguera, they're doing the WeTrust study where they're skipping CT altogether and they go straight to the cath lab and they do the Dyna CT or the Expert CT on the angio suite, and then they just make a decision right there. So there are extremes in that end too.
Yeah, this is another way. So the direct angiography, it's a good idea.
Well, we can invite questions from the audiences. Can put their questions in the Q&A box. In the meantime, if there are any questions from the panelists are welcome. You can switch on your mics, panelists, and interact with Professor Nguyen. My co-host Liu Boon Seng, any questions from you?
Yeah, thanks, Raja. Thanks, Professor, for a very nice presentation. I have two questions, Professor. Regarding using non-contrast CT to decide on mechanical thrombectomy. May I know how many percentage of patients that while going for plan for mechanical thrombectomy and found to be a negative for large vessel occlusion? And what's the reason for that? My second question, Professor, despite a shorter turnover time for a non-contrast CT patient who underwent mechanical thrombectomy, what do you think the opinion, why in terms of outcome, it doesn't make differ compared to those with a CT perfusion and MR? Thank you, Professor.
Sure. So the first question being what percentage of patients don't have a large vessel occlusion in the late window? I think the estimate number, if that's a correct question to answer, the estimate number for large vessel occlusion is 10 to 20%. There's a big range depending on selection, whether you're at the comprehensives versus the primary stroke center. So that range is wide. And then for the next question, why is there no difference? I think it's because it doesn't matter. The outcomes, the vessels, the brain, they're agnostic to how you're selected. If you have brain to salvage and the CAT scan looks just as good as in the early window, then you have potential for benefit, even if you're treated whether by plain CT or advanced imaging. So it's all about, you know, what you think is the clinical imaging mismatch, and you can use that as a surrogate with regular non-con CT, and you don't need to see that penumbra on that advanced imaging to make that decision. Your patient looks bad, NIH of 17, you know there's a big deficit, and you know there's a large vessel occlusion, so that's a great patient to chase.
Thank you, Professor.
Thank you very much. Any comments from Professor Panikkar?
No.
Thank you. Professor Takashi Kon has joined here. Any comments from you?
Yeah, thank you. The next presentation, I'm Dr. Kon from Tokyo, Japan. I own the PSC. So because we estimate, evaluate the patients using by MR image, MRA, using MR large vessel occlusion, and diffusion flare mismatch for indications. So it will take time. So however it's time. So sometimes I'm very suffering. Time to puncture is very important. I understand time to puncture important. And how they evaluate before thrombectomy? Which is important. How to evaluate important pre-thrombectomy? Much more. So NCCT will be enough, or sometimes we evaluate enough. The diffusion and flare, so it will consume time. So I understand, but we estimate before thrombectomy. So if the NCC non-quant CT scan is enough for evaluation, so earlier it would be better, I understand.
Yeah, great question. Obviously, diffusion and flare mismatch is extremely sensitive, and you were able to show that from Rescue Japan, this very successful large core study, that by just diffusion flare mismatch, you were very successful in selecting patients with large core and even show a benefit. So that's an extremely valuable technique. But if it takes time, and if you have a non-con CT, easy to go in and out of the CAT scan, 10 minutes, then that, based on our study results, if you have a good looking aspect score, being aspects of 7 to 9 was the most for the IQR interquartile range in our study, then I think you have enough evidence to, not enough evidence, but enough alternatives to say, okay, I can just take this patient to angio if there's a large vessel occlusion. I don't need to get additional MRI to prove that there's a huge infarct or a huge flare infarct.
Thank you. There's enough to surrogate and CT scan.
So.
Okay.
Yes, it's not going to make level 1 guidelines because it's not a randomized study, but it could be level 2 recommendation if the guidelines are revised.
Okay, thank you.
Thank you very much, Professor Takashi-kon. There is one question which has popped up on the chat box. In the decision making using NCCT, is it still important to do CTA or MCTA prior to bringing patients to cath lab?
That's a great question. So we do recommend CTA because most of the trials used CTA for selection. But if you have a hyperdense vessel sign and you have a patient with, the gaze deviation and contralateral hemiplegia, this is a patient screaming, I have a large vessel occlusion. So in some paradigms, you could just use that alone. But the problem is if you don't see that hyperdense vessel sign, then there's an uncertainty that there is a clot. So that patient could have a seizure, for example. And so you want to make sure you're selecting the right patient. And if you're going to wake up the neurosurgeon at 2 a.m. in the morning, you want to make sure there's an occlusion that he or she will chase after. So CT-CTA should still be the mainstay, because if you miss it, then you lose more time to go back to lab to see if there's an M2 or an M3 occlusion that might alter your treatment decisions for that patient. So we do recommend CT-CTA, but if you are with the patient, you see the hyperdense artery, or if you're thinking I want to go straight to the lab, you can go straight to the lab based on your clinical imaging mismatch and bypass the CTA. But overall, if I had to recommend for a stroke center, continue to use the CT-CTA.
Thank you very much. If I would like to inquire Professor Nguyen about have you explored the whole database and found the association of another innocent bystander in the form of an aneurysm or AVM in your study?
So we weren't looking at that specifically, but certainly when you're doing a lot of CTAs for these stroke patients, we find a lot of aneurysms, AVMs less commonly, as aneurysms are probably present in about 2% of the population. You'll see probably 2% of these CTAs demonstrating an aneurysm.
Thank you very much. Recently, I saw a paper in one of the journals which evaluated stroke and found quite a number of higher number of aneurysms. Well, thank you very much. It was a great lecture and we all really enjoyed it. I would like to hand over the podium to Professor Miyachi to hear his final remarks. Professor Miyachi.
Yeah, thank you very much. It's a very nice discussion. And I think in the only the non-conscious CT is a very useful tool for the late time window. And I think, as you said, the very early patients with such a mismatch imaging will be so essential. I think so. Yeah, but it's a very nice lecture. Thank you very much.
Thank you, Professor Miyachi.
Thank you very much. I would like to inform our viewers that as of now, we have around 985 people who are live watching this webinar on WeChat, YouTube, and Zoom. And we're extremely thankful to Professor Shubin for broadcasting this on the WeChat channel. I would hand over this podium to Professor Dilip Panikar, who is a chair for the second session. Professor, all the best.
Thank you, Dr. Raja. And I must commend Professor Nguyen for the excellent talk and for the lovely discussion that followed. I think that's very, very interesting. And this is always going to be a subject that's going to generate a lot of interest and discussion. The second is also something equally interesting. the awake surgery for various brain lesions is something that has seen its ups and downs, but of late there has been a resurgence with newer indications, other techniques, and I'm sure that everybody would agree that there are as many different ways of doing awake surgery as there are people practicing it. Each person has their own nuances, their tricks, their tips that they use. And every time we discuss this, we always learn something new about the finer points, what works for one and delivers the results. Professor Inam will be talking about his experience about awake craniotomies, especially in a resource-constrained setting. And I really look forward to listening to him. Professor Inam, the floor is yours.
Thank you, Professor Panikar, and thank you, Professor Raja, and the panel, and Professor Kato, and all the ACNS for giving me this opportunity to talk on this topic. This talk is not about, so let me actually share the screen while I do that. So this talk is not about the technique of awake craniotomy. I'm always humbled by the amount of experience that all the neurosurgeons have across the world, and so I learn from everybody. But then, the point that I want to make is that awake craniotomy, of all the places in the world, is more suitable for low and middle income countries, resource limited settings. So that's the point I want to make over here. I will take this opportunity to introduce some of the logos. This is where I work, AKU, Aga Khan University. I came back to Pakistan from USA in 2004, 2003, and since then I've been at AKU. Spent about 18 years there. I have formed these societies, Pakistan Society of Neuro-Oncology. It's been a few years, has been doing a great job. And then this Brain Tumor Foundation of Pakistan, formed by the wife of one of my patients who died of brain tumor. She has done a great, excellent job. This is a sister society that works from the patient's perspective. I've also formed this neuroscience society because deep in my heart, I'm still more into neuroscience than into neurosurgery, and still struggling to make this a popular field in Pakistan. And recently I formed this Pakistan Academy of Neurological Surgery, which forms the platform of a lot of educational activities without any politics, without any elections, without any offices, just teaching and training. So hopefully get there. So thank you very much for doing this thing. I will go with the, let's see. How come I'm not, yeah, okay. So disclosures, no financial, no conflict of interest. So I will start with this thing. This is a 63-year-old gentleman. So what I will do is in this talk is I will talk about the global health aspect of brain tumors, which connects to the awake craniotomy. So I will introduce the global surgery also. So this is a 63-year-old male who came to me several years ago, and he came with his son who was 30 years old or so, and he had some grandchildren. But this gentleman who came, he was in a declining mental condition and with some hemiparesis. And when I talked to his son, I told him that yes, we can take care of it, but then well, this looks like a GBM to me. We can take care of it, and we can arrange for welfare to cover the cost, but then radiation and chemotherapy will still cost him a lot of things. And he said that he wants everything to be done for his father. I said, how much money you have got? Because we don't have an insurance system over here, so effective insurance system. And he said, I'm talking about it in the terms of money in Pakistan rupees. So he said he has 12 lakh rupees or so that he can sell his land. I said, the whole cost may cost you more than 12 lakh rupees. He said he's willing to do that. I said, if we do everything, that will give your father maybe on average, maybe 6 more months of life or 9 more months of life, 9 more months of life, and you will be under debt. You will not have your source of income, and your children, their education may be affected and all that thing. So I think that reasoning hit him, and he decided what I had recommended to him, comfort care, and just let it be. But it breaks my heart, 63-year-old man. I mean, in USA, we would be treating it so aggressively. But here, despite arranging welfare and everything, this is what was the case. And another gentleman, 36-year-old, came from up north of Pakistan, uh, and the session was pretty good, but then he did not follow up on a regular basis. And then when he came back after 2.5 years later, there was significant recurrence, and then again I lost him follow up, and that made again a big impact in my mind, that that we need to address this. We need to take care of each patient individually. That's good, but we need to address it at a bigger scale. And that connects to my good friend, well, I call him friend, I don't know if he calls me a friend or not, Sanjay Nagral. This is Professor Bhutta actually pushed me to write this paper with all these colleagues, and the unmet need for surgery in South Asia. So looking at from that perspective, going beyond neurosurgery. And if you look at it, the population in Pakistan, India, and Bangladesh, and China, I mean, we are in the top few countries in the world. Now, China has a good GDP and all that thing, but India, Pakistan, Bangladesh, our income is very limited, and this is what it shows, the low income countries. So this is where we are, and this is a highly populated area. So these are low income over here, but not as much population as we have in this part of the world. And about 50% of the world's population lives on less than $2.50 a day. This is more than 3 billion people we're talking about. That's a lot of people. The aspect of burden of surgically treatable conditions, they drastically outweigh burden from top infectious killers. So we talk about public health, we talk about TB, we talk about HIV and AIDS and malaria and all that thing. But the fact is that it's the global public health aspect of surgery which is the main issue. So surgically, if you look at the surgically treatable conditions versus HIV, AIDS, tuberculosis, and malaria, they're all dwarfed by this thing. And about 1/3 of the global burden of disease can be attributed to surgically treatable conditions, of which neurosurgery is a part of that. And the Lancet Commission on Global Surgery, by the numbers, if you look at it, they're talking about there are about 5 billion people in the world without access to safe and affordable surgical care, and about 21 trillion estimated loss in global productivity between 2015 and 2030 without urgent and accelerated investment in surgery. So we're talking about big numbers from all those aspects. If you look at the proportion with no access, with no reasonable access, then the number goes all the way from 5 to 9% in Western Europe to South Asia, which is about 99%. So that's a significant difference. About 99% of people in South Asia have inadequate access to surgery, whereas it's 5 to 9% in Europe, and in the USA. I don't have here in USA, but high income North America 0 to 2% here. So there's a big disparity. We have to understand, we have to realize that disparity. And it was Jim Yong Kim, when he was president of World Bank, he said that he is the one who brought attention of us to this issue more. And John Mayara write in this thing, for many it is simply lack of money, for others it is the tyranny of distance and poor transportation infrastructure. For the remainder who can afford it and can travel the distance, they arrive to find a feeble healthcare system with too few surgeons or anesthetists, no medications, no oxygen, and no blood for needed transfusion. In an era in which we discuss the dawn of personalized medicine and genetic engineering with frequency and familiarity, how can we allow more than half of the world's population to live in a healthcare time warp, trapping them centuries in the past? So that basically brings to the point about the global health aspect. Now, when it comes to the brain tumors, because awake craniotomy is more to do with the brain tumors, I have done some study based on the Pakistan Society of Neuro-Oncology made a consortium. There are people who actually, more than 50% of people had to travel more than 50 kilometers to get there, and about close to 20% of people had to travel more than 500 kilometers. And then, in this study, a lot of patients travel from neighboring LMIC, Afghanistan, and other places. The distance that you have to travel, if you look at the distance to hospital, depending on the income country, this is high income countries, low and middle income countries, long distances they have to travel. And then obviously, there's this disparity between a private sector and a public sector in all these countries, whether it's Pakistan or other LMICs. The private centers are pretty good. They're high standard, more accountability, but they're not of reach for most of the patients. Whereas the public sector, they are so much crowded and lack of hygiene and long waits and whatnot. They may have big ticket items in there, but then they are not used appropriately. And then the issue is, where there is no insurance. So, for example, things might have improved a little bit over here, but the population with insurance is pretty low in this part of the world. The cost of craniotomy may be something about US dollar $300 to $6,000. GNI per capita. This is actually this number has decreased further in Pakistan. Much less per capita income. So one craniotomy can cost a lot of money, and for that purpose, there are a lot of centers which give philanthropic money. This is Shaukat Khanum, our Prime Minister's hospital, free services, but then it can take off a certain extent. Uh, that's more of a private thing, not the public. It's not the governmental level. So the credit does not go to the government. I mean, he is the prime minister, but it's not the government that's doing it. It's something that he started at the private level. This is another hospital that's free treatment totally by philanthropy. At AKU, we have been giving more and more money in welfare because we are a non-profit organization. The money issue is significant, where uh, the medical costs and the medical plus non-medical costs, they can affect those in the lower quartile and in the higher quartile. So in low income countries, people in the low and high quartile are affected by these costs. People in high income countries are not affected so much. Every year, the catastrophic expense, the catastrophic expense is basically that pushes you below the poverty line. The catastrophic expense is about 44 million household, about 150 million individuals affect that. And about 25 million households every year are pushed below poverty line because of that big expense, 100 million individuals. And this is the data from Lancet Commission. And that is all because out-of-pocket payments, low household capacity to pay, and lack of prepayment mechanism for risk pouring. In that, the tumor, the neoplasm, the cancer, that has a much bigger proportion. So if you look at from the 2015 to 2030 projection, you see this blue thing, this blue line, part of the line, that is increasing more proportionately. So cancer will become bigger source of catastrophic expense as time passes on. If you look at this graph, where it is a combination of blue is reported distress financing and estimated catastrophic health expenditure, whereas this is expense but not catastrophic expense. The 91% in cancers, that is the highest catastrophic expenses. Excuse me. So we suffer much more as a cancer patient in terms of finances. and Asia has the highest number of cancer cases because of the population. And interestingly, the if you look at the new patient consults per year per oncologist, it is much higher in LMIC. The number of patients per oncologist. That's a stress that oncologist goes through by seeing so many patients. You cannot be nice, and you cannot be kind, and you cannot be thorough if you have so many patients. And here Pakistan, we actually at the top of this list over here. And then other low income countries, but then even China is also not doing in a very good shape compared to global median over here. so what we do is we still keep on saying, okay, this is how things are done in North America, this is how things are done in Western Europe, and we just say this, do the same thing. We can't put a square peg in a round hole. When I came back to Pakistan, one of the first thing that I noticed was that the cost of clipping versus coiling, and I published this article, this is back in 2009, that why should we use coiling for when we looked at the outcome, and we realized that the clipping, the coiling, this blue, was much more expensive than the clipping because of the coils were very expensive, and the good outcome was the same whether it was clipping or coiling, but the cost was different, $3,000 over here and $5,000 over here. So if you look at we decided to work on the risk factors based on patient age and rhythm location and nurse grade, and based on that, the decision making table that I used for clipping versus coiling, that why should I use coiling if things can be done clipped with a similar outcome and much lower cost. Which then brings me to these expensive items. So I think most of the people know about Gliadel wafers. I used to use Gliadel wafers very commonly in USA. Now, the cost of a craniotomy in Pakistan in AKU, which is more expensive than a public sector, is about $4,000 to $5,000, and the cost of this Gliadel wafers is $11,000. So I used to use it very frequently in USA, but I have not used it in Pakistan except for once when the insurance covered it. Doesn't make sense that you are doing a surgery of about $5,000 and you put a Gliadel wafer in for $11,000, which may have maybe a month and a half, benefit and survival. Similarly, we got this expensive microscope, but the 5-ALA, I have still to find a cheaper source. It's about $1,200. Now, yes, it does improve resection, but it does improve maybe survival a little bit, not a big difference if you look at it, but then it adds 20% to the cost of a craniotomy. So really, do we have to use 5-ALA? I mean, fluorescein doesn't work very well. So we have to think, we don't have to just follow that way, and we got this neurorobotic exoscope in AKU through some philanthropy, and I think that was not really a good way of spending money, because the company has not been very forthright and supporting our effort to do this. And then even neuronavigation, it does help, and I use it very frequently in my teaching. We have 2 or 3 of these navigation systems, but then not every hospital that does neurosurgery in Pakistan can afford this thing. So I would go back to the old ways that my mentor, Dr. Ghaus Malik at Henry Ford Hospital, would insist. You got to know the anatomy, you got to get to the tumor without the help of navigation system, and that's what we need to train. We do get DTI, and we do sometimes get the functional MRI, but then functional MRI is very expensive over here. It just adds to the cost. So all these things have to be considered in the terms of global health aspects of management of brain tumors, and that's where I use the term of global neuro-oncology, and that's the goal of the society that I formed, and look at the holistic aspect of this thing. I've made a consortium of all these of major institutions across Pakistan, and did a Pakistan brain tumor epidemiological study, and there were a lot of gaps that we identified in the management of brain tumors in Pakistan. But then I think to fill up those gaps, to take care of those, we need to address them by looking more into molecular epidemiology, maintaining a registry, coming up with artificial intelligence and virtual biopsy that will help us help against misdiagnosis across the country, and developing good algorithms so that things are taken care of appropriately. Telemedicine is another cheap way of doing things, and we need to move towards that. And one of our colleagues, Noreen Mushtaq, she went to actually a hospital for sick children, and she's been twinning this with pediatric neuro-oncology and doing an excellent job throughout the country of pushing everybody towards interdisciplinary neuro-oncology tumor board. In whole Pakistan, the only place that we have is only one institution where we do a regular neuro-oncology tumor board. Otherwise, there's no other place that do it regularly. And these are the things that are very important to improve the outcome of the patients. And then we need to train. We need to train clinician researchers who are mindful about what is the issue in their locality, in their area, not at a different level. First try to fix things around them. I put this picture over here because my mentor was Malik. When I was going back from USA to Pakistan, I was in the final years. He said, we used to do laminotomy with a very Midas drill and all that thing. He said, no, you got to learn how to do it with this also, Hutzel brace. I can bet you in the current, those who are 10 years younger than me, none of the neurosurgeons have done a cervical laminotomy with this thing. But he taught me to do that. In resource limited settings, we need to learn how to use simple tools, simple instruments without much expense. So awake craniotomy comes in that perspective, and we wrote about awake craniotomy, review of hurdles, and there was not much done in different countries in our part of the world. There are different ways of doing awake craniotomy, but the hurdles that we found was in the extent of disease was much bigger tumors. Patient awareness was an issue. Patient selection was an issue. And then, for the longest time, we were not able to do awake craniotomy because we didn't have the drugs, and the anesthesiologists were really not interested. This is one of my awake craniotomies back in 1992 when I was at Henry Ford Hospital, and then when no, sorry, that was not 92. That was that was 1999. And then when I came to Pakistan, I could not do awake craniotomy for about 10 years plus, because there was lack of cooperation from anesthesia, and I had to fix them. So I had to take them to back to USA, one of the anesthesiologists, and showed them how it's done, and then suddenly a light bulb sort of turned on, and they got interested, and then it came up with a lot of papers also doing awake craniotomies over here, and that has helped a lot. Although we do get DTI because at AKU we can afford that, but not a lot of institutions have all these softwares. But it's not this DTI that's important. What is important is the awake aspect. With the awake aspect, you can actually do a gross total resection of these tumors. This is a low-grade glioma of a 36-year-old male, and here is another gross total resection of another tumor on the left side, a little away, but then a little away from the speech area, but close to the motor cortex. And all these patients did well. This is a GBM, going all the way to the motor cortex and the corticospinal tract. And again, I got these, but I can tell you that I did not rely on the DTI as much I relied on awake craniotomy in removing this brain tumor and gross total section of a GBM from that purpose. So what I learned was more important is cortical mapping and subcortical stimulation also. That helps a lot. And this picture is, I think, from Mitch Berger's paper. I forgot to put a reference over here. I think so, yeah. So what is important is actually subcortical mapping. So you may not need to do so much of expensive MRI techniques and all that thing. Just simple stimulation, which is a very cheap instrument. If you do that, and you keep on stimulating, and it's a little painstaking work, but you should be able to get good better results. Our awake craniotomy for excision of brain tumors, with the first 200 cases that we did, and we found that first of all, it was a good outcome. The hospital stay was significantly lower in awake craniotomy, AC 3.15 days, and general anesthesia 5.26 days, and they were comparable groups. 200 awake craniotomy and 100 GA patients. The gross total resection was more so found in awake craniotomy, near total resection more so in awake craniotomy. Look at the percentages though, not at the total numbers. And the maximum safe resection was also better in awake craniotomy. And then the improvement from the pre to post-op was again much better in awake craniotomy. I will show you in different here it is. If you look at it, the improvement, the blue is awake craniotomy and the green is general anesthesia. So improvement was better in awake craniotomy, preserved neurology better in awake craniotomy. KPS deficit of 10 or more was a little more in awake craniotomy, but 20 or more was much more. So these are negative things, but it was much more negative in the general anesthesia. The interesting thing that I found was, and I think most of the awake craniotomy experts have found this over time, is that these patients who develop this deficit, they actually the awake craniotomy patients do much better. So late, this is the early, and this is the late. So if you follow these patients in your clinic later on, you find that the deficit, the KPS deficit of 10 or more, improved a lot in the awake craniotomy, whereas in the general anesthesia, and same thing, KPS deficit of 20 or more. So what happens is that you stop right there when there's something happening, and when you stop right there, the patients, they do much better. And despite you stopping right there, you have a better preserved neurology and more gross total resection. So that was for the tumor, but the awake craniotomy can be used for other purposes also. And I want to talk about this 20-year-old female, and I have done several cases. And Salim Abdurrauf, one of my colleagues from Henry Ford Hospital, is and University of Missouri, he does a lot of those awake craniotomy for vascular. And I think what he says makes a lot of sense, that it's the vessels that you clip, and if you clip temporarily and you see the neurological outcome, that makes more sense. So this is, for example, this 20-year-old girl with the right next to the Wernicke's area, big AVM over here, and my fear was that while removing this, we can cause deficit. So if you notice that is being fed by the left PCA as well as the Picus branches. And if you look at this one also on the lateral view, you can see it, that left PCA supplies it mainly, and some very fine twigs come from the lower ones. And the left ICA and the left MCA supplies most of it. And this again is the left MCA supplying most of it. So embolization was obviously did some work, but then it's an MCA, so they're afraid for embolizing it also. So here's the benefit of awake craniotomy in these kind of cases. And yes, of course, I don't do resection that fast. This is sped up. But so while this was being done, I was able to keep on talking to the patient, and felt very comfortable that she's doing fine, resected. But then there was this vessel which was still there and bleeding, and I did not know if it was supplying an eloquent area or not. So I put a clip on it, and usually you do ICG, which are expensive and all that thing. You put a clip on it, wait for 5 minutes, and if there is no neurological deficit, then one can easily remove that, and and feel good, feel safe about it, compared to if you don't do it as an awake craniotomy. And post-op, which is standard, to get no residual AVM there and no residual AVM here. So so these so this was the benefit of awake craniotomy. And here is another example of awake craniotomy for another AVM. Little complex history. I don't need to go into that history as much, but 32 years old, left-handed male with very complex history. But enough to say that this vessel was, I wasn't sure, because there was so much that had happened in this area of his brain, because of previous history of going through different operations at different centers. When I opened it up, I was like, could not figure it out very well because of scarring and all that thing. So again, putting a clip on one of the major vessels that was going into the AVM gave me that confidence to actually make sure that yes, this is okay. So yes, I know one can use ICG and all that thing, but again, this is just a very cheap and simple way and this is much better than ICG and all those things. So we published that also, awakening for the section of cerebral arteries malformation. And not only that, so we are using awake craniotomy for a lot of other things also. I mean, there is like a sort of a myth about that awake craniotomy cannot be used for meningiomas, extraxial lesions. We found that it works very well. It's pretty safe and very well tolerated. So why not do that as well? And here are a whole bunch of meningiomas, large meningiomas removed as awake craniotomy. Pretty good grade 1 or grade 2 resection, Simpson resection, and the neurologically improvement or no change in patient, no deterioration was found. So basically, the benefits of awake craniotomy in the resource limited settings is, number one, it's cost effective. There's less need for equipment for that because of this awake, and we do awake, so we really don't need much equipment. We don't need to. The neurological outcome is better and is suitable for LMIC. So thank you very much for listening to me and for making my point come across to you. Thank you.
Thank you, Dr. Inam. I think that was a very interesting talk about your indications for awake craniotomy and how you have extended the use of this technique to a wide variety of conditions to make it more effective, more universally applicable to a wide variety of conditions, and to help with reducing the expenses that are associated with this entire treatment protocol, reducing the utilization of material and reducing the time. I think one thing you have brought out very clearly is the fact that the confidence that an awake surgery gives both the surgeon and the patient, when you know that your patient is neurologically intact and well through the surgery, at the end of the surgery, you feel a sense of satisfaction that, yes, I've done a good job, I've taken the tumor out and my patient is intact. You don't have to keep biting your nails at the end. Is he going to wake up? Is he going to wake up with a deficit? Is he going to wake up and talk? I don't know. At least this way you're confident. I'm happy. I'm good. He's talking, he's moving, he's conscious, he's happy, I'm happy. So I think that gives you a great deal of satisfaction. The practice of awake craniotomy, I think there are the proponents and the opponents of an awake craniotomy. I think both sides have their own merits and their demerits. But what I personally believe is the more you use an awake procedure, it is not only the surgeon, but also the entire operating team that gets caught up in this.
Absolutely.
And then it becomes a very routine practice. One does not have to struggle to set up an awake procedure. I think this is something that's very, very important.
Absolutely.
Never use it selectively. Use it more often than what you think is necessary. You will find the benefits when you have a really difficult case.
Absolutely, I totally agree with you on that one. Don't keep it for those few cases. So every country has its own political thing among the surgeons. So I have been criticized in Pakistan, those who don't do awake craniotomy, that he's doing too much awake craniotomy. There's no need to do awake craniotomy for a right-sided. I said, you know what? It's going to be less length of a stay. Might as well do it awake over there. What's wrong with it? And as you said, it just makes the team much more comfortable, and things go faster. By the way, the satisfaction thing that you're talking about, when you do get deficit, so you are at the edge in general anesthesia when the patient wakes up, but then when you get the deficit in awake craniotomy, your heart sinks so low below, you feel so bad. But then after 2 or 3 days, you always feel good because they start to recover much better. But there's a sinking feeling in awake craniotomy also.
Yeah, I think that's very important. I have a question here. When you do an awake craniotomy, say for a glioma, say for the glioma in and around the speech areas. What kind do you use the subcortical stimulation, the cortical and subcortical stimulation mapping as a routine, or do you just
Yes,
follow the patient?
I do use it as a routine, and I do only negative mapping. I know there are proponents and opponents of that about negative mapping versus, I mean, Oogie Dufau would like to open the whole thing up, and even Mitch Berger. I think Mitch Berger has moved towards negative mapping also. I mean, I may be wrong about it. Jinsong Wu does an excellent job in China in awake craniotomy. I, do small opening, just look negative mapping. And the other thing is, I have not been able to have a neuropsychologist over here also. So that's another thing I wanted to talk about, that, awake craniotomy needs a big team and all that thing, but you don't need a big team. I mean, if you can afford to do it, I would like to travel in a business class from here to Boston if I can afford to do it, right? But if I can't afford to do it, I will take economy class. I'll get there, okay? I can have a Cadillac and go from point A to point B, and I will enjoy the ride in a Bentley, right? But if I have a Corolla, I will get to that point. So a neuropsychiatrist, I would like to have one, but then I have not been able to get it because there was nobody available to do that. So what we do is, there's a whole team of residents and medical students, and we just manage it ourselves. We do a smartphone. We have some questions. I ask the patient to count, to give the reasoning and all that thing, and so like you've seen those videos where they're playing music and all that thing. I mean, in this part of the world, some people are very much into reading Quran, just like in India they would be interested in doing bhajang. So I use that. I mean, you can use that in India. Come on, if you want to do the bhajang, the intonation and the memory of all that thing, if you can do it in a very well way, that means all those things are intact. So here they do the kirat of Quran, and I listen to that. If I see some changes in that, and I know there's something wrong happening, so I use all those different things without using a neuropsychiatrist. If I could afford it, I will do it. It works. It works okay that way for me.
Yeah, I think the key is to improvise with whatever you have.
Right.
You'll never have the ideal situation where you have trained personnel. It's good to have a speech pathologist, good to have a neuropsychologist, a trained neuropsychologist who's interested in coming into the theater and assessing your patients, a good speech pathologist who can tell you everything about the speech.
Right.
But then if you don't have it, you improvise. You just make the best of what you have, but you don't say, no, I will not do it because I don't have these people with me. I think you're absolutely right.
Right.
It's a surgeon's feel. It's what you listen to.
Absolutely.
And that tells you what's happening to the patient. I think that's fascinating. That's absolutely fascinating. And a very, very important point that you have brought out here. Don't be afraid of doing an awake craniotomy because you don't have all these things. Do it with what you have. And just improvise.
Thank you very much, Professor Attarinam. What a fantastic lecture it was. Indeed, the cost effectiveness of various treatments are the soul of every LMICs. I read recently from a social media post that the middle class is just a single hospital bill away from poverty, which you have highlighted very well in your lecture. We can invite comments from my co-host, Dr. Libun Singh.
Thanks, Raja. Thanks, Professor, for a very nice presentation. I probably want to get your comment, Professor, regarding the cost of a treatment. As you know that when medical treatment advances, we always redefine what is optimal and what is suboptimal. And because of that, the cost of a treatment become higher and less people will get benefit from the treatment. I want to ask Professor, how much basic can we go back in treatment, especially for neurological or neurosurgical patient? My second question, Professor, regarding the cost of treatment, the technology, in your opinion, for global neuro-oncology, you think that rich country supposedly to subsidize the cost of technology for the poorer country to ensure equity in the treatment? Or do you think that should we have a different definition of the standard of care for both high GDP and low GDP countries? Thank you, Professor.
Thank you. I actually did not understand your first question very well. I can answer the second question first. So for the answer to the second question is, well, even in the high income countries, they are constantly looking for cost cutting, because most of the cost in USA, North America, goes to insurance companies, goes to the pharmacy vendors, and the hospital management. And I remember at Henry Ford Hospital, we were always constantly talking about that, we can't do this, we can't do this, we can't do this. It's cost cutting. But over here, a craniotomy is about $5,000 in a private center. Over there, a craniotomy was about $80,000 to $90,000. So no, there's a big difference, huge difference, right? So their cost is very high, and I don't think the outcome is different. I actually have another study that I did, and one of my students who was trained in neurosurgery in USA. He was at University of Kentucky and then went to Montreal Neurological Institute and back in University of Kentucky. So we looked at the group of glioma patients in Karachi, in AKU, and in his. And actually, maybe the pathology is different, but the overall survival, and the progression-free survival was better in AKU than in University of Kentucky. So, so I don't think that cost cutting is going to affect the outcome. I mean, here's an example of awake craniotomy, which is a sort of, in a way, cost cutting, but the neurological outcome is better. So why not do that? So that's the answer to your second question. Your first question, I was not very clear what you wanted to ask.
Yeah, actually, what I mean is, because of the advances in technology or in medicine, we need to redefine what is considered optimal and suboptimal. I think that redefinition causes higher cost in treatment, and that actually discourage more surgeons to treat a patient, because they do not want to fall into suboptimal care, and actually that cause more patients that do not get the care that they need at least. So in your opinion, Professor, how much basic can we go? Can we go without IGS, things like that cause effectiveness in our treatment? Thank you, Professor.
I mean, Professor, you and all those people over here, you are all aware that how much our treatment standards are driven by financial reasons. So, when I was in USA in practicing, there was, I was putting in screws left and right, putting so many screws in there. And there were a lot of papers coming out, about fusion. And over in Pakistan, I realized that, because people have to pay out of their practice, and I don't see that the outcome is significantly different. You don't need to put the screws. And so there are much less number. And, I went to one of the meetings recently, not recently, maybe 5 or 6 years ago. And there was a whole lecture on this, that if you have a synovial cyst, you fuse it. I mean, for God's sake, for a synovial cyst, are you going to fuse that level? For God's sake. And I know there's a little micro motion. I have never fused for synovial cyst. And there's only one case, I don't do spine anymore, but there was only one case I remember when there was a recurrence of synovial cyst, and went back in and removed it, and that was fine. Why are you fusing it? It is all driven. I mean, I was practicing in Michigan, and there was this gentleman, and I will not take his name. That neurosurgeon, there was a time, I don't know, maybe you're too young. What we call is rage of the cage. People are putting cages, left and right at all levels. This person in 1 year had put in 300 plus cages in spine. And I would scratch my head that, I see a lot of patients, but I don't see an indication. So what happens, there's so much driven by these vendors, by these commercial agencies, that you end up doing those things which are, make certain sense. And you just keep on, it's a slippery slope. You keep on falling down. And that's what I find in North America. It's a slippery slope, fuse everything because the screws are available. Let's do it. I used to see so many whiplash injuries in USA. I've been here practicing 18 years. I've never seen one whiplash injury in Pakistan. Not a single whiplash in 18 years. Because there's no incentive for that. No, you don't sue people for whiplash injury. You don't make money out of it. So it's all driven by all those things. So standards are they really standards? Maybe not. So we need to step back. We need to say, what is right thing for our own locality. That's the way I look at things.
Thank you very much, Professor.
Thank you very much. I would like to ask one question to Professor Inam, that our surgeries are inherently associated with many complications, which may be in the form of seizures or it may be from of an anesthetic complication. How much of cases you have had to abandon and revert to a GA in your practice of awake craniotomy?
So not a single case. I didn't have to do that. Not a single case. There was, I would say, couple of cases where I had to. So usually I stop in resection when I've reached the limit, when I start to get a neurological deficit. So I would say there were maybe 2 cases that I remember out of those 200 cases. The way I've done 200 plus cases, where the patient became very agitated. So I had to stop resection. And then I looked back and I said, look, the purpose is to get a biopsy, and the purpose is to do maximum safe resection. So I got a biopsy. If I go back in again for maximum safe resection, why do that? So we just stopped there and look at that. So I haven't had to convert into GA or go back another time with a GA.
Thank you very much. Professor Takashi Kon, any comments from your side?
Yeah, I think it was great talk. I'm Dr. Takashi Kon from Tokyo, Japan. I'm doing a glioma surgery, so I used a 5LA and navigation to removing glioma, but we seldom use gliadal wafers because it's too expensive and too costly, even in Japan. So even in Japan, so medical cost is very important problems. So in your country, the diagnosis in genetic pathology, and after the surgery, chemotherapy and the rehabilitation is also costful in Pakistan. Sometimes patients cannot afford to give up the treatment. In that case, will happen in your country?
Yes, Professor. It is the case. The Pakistan brain tumor epidemiological study that I have conducted, which is a retrospective study in the pre-COVID era, we're going to be coming out with a series of papers on that one. There's a significant gap. So we got the documentation. So I work at AKU, which has better documentation, all that thing. But even over here, the patients, they're lost to follow up. And there seems to be a significant number of patients, which may be as much as 30 to 40% of patients that did not get any adjuvant treatment, like therapy and radiation therapy. Because even though you tell them that, hey, look, you got to come back and do this, they think, okay, surgery is done and, I'm done with it. And then you see, like, for example, the one I showed as a second case, where this gentleman came after 2.5 years with a big recurrence. So that is an issue over here. As far as the affordability is concerned, yes, it is expensive. But then there are centers which are not very standard centers. There are more complications, but they are government-based radiation centers are available. And as far as chemotherapy is concerned, we get some better price temozolomide from India that we get over here, because if you get it from USA, it's more expensive. All of that adds up. All of that. But I'm very interested that in Japan also you're looking at gliadel as an expensive treatment without much benefit. But if you notice, there are big symposium were done and big stalls and nice trips offered by the by companies to push those things. And I remember one of my mentors, Mark Rosenblum, he was very dismissive of the gliadel wafer early on. I'm talking about back in 1999. So that it's not doing any significant benefit. Why are we using such an expensive thing?
Yes, a very expensive. I understand. Thank you.
My pleasure.
Thank you very much. Well, indeed, we had a wonderful lecture today. Both the lectures were very fantastic, and I would like to hand it over to Professor Dilip Panikar to hear his concluding remarks.
I must congratulate Professor Inam for his excellent overview of the importance of understanding the burden of surgical diseases per se, which I completely agree with you is undervalued. The public health concerns of communicable diseases probably overshadow the importance of this, and that gets most of the attention and the funding. But the burden of surgical diseases, of surgically remediable diseases, doesn't get the attention as it should. And that over time does become a problem. I mean, you have brought it out so well. And your excellent exposition on the application, the practical applications of the awake surgery, which itself is fascinating. Thank you, Professor Inam. I think that was very nice. We all enjoyed your talk.
Thank you, Professor. Thank you.
Thank you very much. And we had indeed a wonderful learning session. So I'll wind this up officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Tan Nguyen and Professor Saida Tarinam, as well as the chairs, Professor Shigeru Miyachi and Professor Dilip Panikar, for the time and support for the ACNS webinars. I would like to express my sincere thanks to Professor Shubin for broadcasting the webinar on the WeChat channel in China. And as of now, we have around 985 people who have joined us live. A special thanks to my co-host, Dr. Liu Boon Singh from Malaysia, for joining in today. So until we all meet on next Saturday, it is bye-bye from all of us. Thank you very much for joining.